All right, if you're a first-year medical student, you are in exactly the right place. Today, we're taking a really deep dive into one of the most critical drugs you'll ever use, epinephrine. We're going to break it all down from the molecule itself all the way to a classic board exam question. So, let's get into it.
So, here's our game plan. We'll kick things off with the absolute basics. Then we'll get into the nitty-gritty of how it works. We'll follow its path through the body, go over all the warnings, and then see how it actually gets used in practice. And we'll wrap it all up with a high-yield clinical pearl that you are definitely going to want to remember.
Okay, first things first, the basics. Before we can even think about using a drug, we've got to know what it is and exactly when we should be reaching for it. At its very heart, epinephrine is what we call a sympathomimetic. Now, that's a term you've absolutely got to know. It just means the drug mimics or imitates the effects of your sympathetic nervous system. The fight-or-flight response that gets your body primed for action.
So let's get a little more specific. Chemically, it's part of a group called catecholamines. Pharmacologically, it's a super potent adrenergic agonist. That's what gives it those sympathomimetic effects we just talked about. And therapeutically, well, this is what it does for the patient. It's a vasopressor, meaning it raises blood pressure, a bronchodilator, opening up the airways, and a cardiac stimulant, getting the heart to pump harder and faster.
So when do we actually use it? Well, its indications are incredibly diverse and almost always for life-threatening situations. It is the absolute cornerstone for treating anaphylaxis. It's also a critical tool in cardiac arrest for rhythms like PEA, that's pulseless electrical activity, anastole, and pulseless VTach or VFib. We also use it for severe low heart rates, different kinds of shock, and bad asthma attacks. You'll even see it mixed with local anesthetics. Why? Because it constricts blood vessels right there, making the numbing agent last longer. Pretty cool, huh?
All right, let's get into the how. This is the really cool part, the core science behind why epinephrine is just so incredibly effective.
Now check this out. What's so fascinating about this table is how it stacks epinephrine up against other common vasopressors. Just look at that row for epinephrine. It's an absolute powerhouse. It hits alpha-1, beta-1, and beta-2 receptors with really high affinity. Compare that to something like norepinephrine, which doesn't touch beta-2, or phenylephrine, which is a pure alpha-1 agonist. Epinephrine really does it all, and that's the secret to its versatility.
And this image just beautifully illustrates what happens next. When epi binds to that receptor on the outside of the cell, it doesn't actually go in. Instead, it's like ringing a doorbell. It kicks off a chain reaction inside. It activates a G protein, which then tells an enzyme called adenylate cyclase to get busy converting ATP into something called cyclic AMP, or CAMP. And that CAMP molecule is the second messenger that carries the signal throughout the cell, starting that whole cascade of effects we need.
So here's the crucial point. Let's translate all that. Each receptor action leads to a specific life-saving effect. Alpha-1 squeezes those peripheral blood vessels, which jacks up the blood pressure. Beta-1 works right on the heart, increasing its rate and the force of its contractions, which boosts cardiac output. And Beta-2 relaxes the smooth muscle in the airways, opening them up so the patient can breathe. It's this beautiful, powerful combination that makes it so indispensable.
Okay, so now that we know how it works, let's follow epinephrine on its very quick journey through the body. Let's talk pharmacokinetics.
The full ADME profile is pretty complex, but for clinical practice, here's what you really truly need to know. Epinephrine works incredibly fast, but it does not last long. It has an onset of seconds to minutes, but its half-life is super short. This is perfect for an emergency when you need an immediate effect, but it's also a bit of a double-edged sword. That short duration is exactly why someone can have a biphasic anaphylactic reaction. The symptoms come back as the epi wears off. And in situations like septic shock, it means one dose isn't enough. You've got to run it as a continuous infusion.
Of course, any drug this powerful comes with risks, and understanding the warnings is every bit as important as knowing when to use it. Okay, this right here is a critical distinction. In a non-emergency, you might avoid epinephrine in a patient with, say, severe coronary artery disease. But, and you have to burn this into your brain, in a true life-or-death emergency, like anaphylaxis or cardiac arrest, there are no absolute contraindications. The immediate threat to the patient's life simply outweighs the potential risks. That said, you still have to be extremely cautious in patients with heart disease or those taking certain meds, like beta blockers, and we'll circle back to that in a bit.
The side effects, well, they're a direct and totally predictable result of how the drug works. You are literally cranking up the fight-or-flight system. so you should absolutely expect the patient to feel anxious, restless, maybe a little shaky. Their heart is going to race. That's the tachycardia and palpitations. And you have to be vigilant, watching closely for dangerous arrhythmias or a huge spike in blood pressure.
So let's take all of that science and bring it right to the bedside. This is how we apply everything we've learned to take care of patients safely and effectively. What you do around the administration of this drug is absolutely critical. So before you push it, get a quick set of baseline vitals and ask about any cardiac history or if they're on beta blockers. During and immediately after, that patient needs to be on a monitor, period. You are watching their heart rate, their rhythm, and their blood pressure continuously, looking for that good therapeutic effect while also being on high alert for any bad reactions. Now, when you're teaching a patient who's going home with an epinephrine autoinjector, this quote is the absolute core message. This device is a life-saving bridge. It is not a cure. Its whole job is to stop the reaction in its tracks and buy them the precious time they need to get to a hospital for more treatment and observation.
And to make sure that message really sticks, you have to use the teach-back method. Don't just tell them, have them show you how to inject it into the thigh. Ask them to explain when they would use it, and make absolutely sure they can tell you that the very next thing they do after using it is call 911. And crucially, explain the idea of a biphasic reaction, that the symptoms can get better and then come roaring back hours later, which is why they have to go get checked out.
All right, let's wrap this up with a clinical pearl. This is a classic scenario that you are almost guaranteed to see on a board exam, or more importantly, in real life, in the ED.
This is the beta blocker trap. So imagine a patient who takes a beta blocker like metoprolol every day has an anaphylactic reaction. They're in double trouble. First, the beta blocker itself can actually make the allergic reaction worse. And second, when you give them epinephrine, the beta blocker is going to blunt the drug's life-saving beta-1 and beta-2 effects. That leaves the alpha-1 effects totally unopposed, which can lead to a really dangerous, severe spike in their blood pressure.
And that leaves us with this really critical question. Knowing this trap exists, how does that change your plan? It forces you to think a step ahead, to think about your second-line treatments, like glucagon, and to always be prepared for when your first-line go-to therapy might not be enough. And that, from the basic molecule to the complex clinical traps, is our deep dive on epinephrine. Thanks for joining me.